Good afternoon, everyone. I think it's good evening for some of you and maybe even good morning for some. And welcome to today's session of our SADS Expert Insights webinar series. I'm Pam Husband, the Executive Director of the Canadian SADS Foundation, and it's my pleasure to host today's webinar. So before we start, I'd like to get some basic ground rules out just to ensure a smooth and productive session. So please note that while Dr. Gonzales Corcia will provide in-depth information on the topic, this webinar is not intended for personal medical advice. So we encourage you to ask general questions, and we hope you will. We hope there'll be a discussion, but keep your questions to a more general nature. And to maintain webinar etiquette, we kindly ask all participants to turn off their cameras and their microphones, mute your microphones, please, during the presentation itself. It minimizes distraction for the presenter and so on. And if you have any questions during the presentation, please feel free to type them into the chat because we will try and address everybody's questions. And also, once the presentation is complete, of course, you're welcome to raise your hand in order to participate and ask questions as well. So I'm going to give a very brief statement about Dr. Cecilia Gonzales Corcia. It's a little bit of a mouthful. And I want to say to everyone that I've had the pleasure of actually meeting Dr. Cecilia personally, and she's every bit as lovely as can be. And I'm so I'm just so grateful that I have met her. And I had a long half-page introduction for Dr. Cecilia, but she would like to introduce herself in her own way. And I think it will be very helpful for her to do this because she will represent herself in the context that she would like you to see her. So I'll just say that at the moment, Dr. Cecilia works in pediatrics in the Faculty of Medicine at the University of Montreal and as a consultant cardiologist and pediatric electrophysiologist at CHU Saint Justine, Montreal, Canada. And so, having said all of that, I will turn it over to Dr. Cecilia. Thank you.
Hello, Pam. Hi, everybody. First, I want to say and admit that it's a pleasure and honor to be working with SADS Canada and having you yourself and Catherine Timothy in the audience who have been working so hard at devoting your lives to sudden cardiac death and to supporting families is for me an honor to have you in the audience and to contribute to the motive of your life. No, so this is the first thing to share. I'm honored to be here, and I wanted just to share with the audience a little bit of how I became interested in pediatric syndrome, Brugada syndrome. I am originally from Argentina. I did my medical studies there, and I also did pediatrics. And after that, I just thought that I would want to train a little bit further, so I trained pediatric cardiology and electrophysiology in Boston. And I then married a Belgian, which made me cross the ocean, across the Atlantic, and I settled in Brussels. And there I had also the honor to work with Professor Pedro Brugada, and I was doing his electrophysiology cases, his ablations, because there was nobody in his group that wanted to take care of the children. And when I started working with Pedro, I was just doing normal EP studies and ablation, but I started to take care also of the pediatric Brugada syndrome children. And I started to see a lot of gaps in the histories of these families. And even if the first person that had presented with sudden cardiac death sometimes was an adult patient, in other generations going up the family tree, there were infant deaths. And I started to be very interested about this. And then I didn't have this economic support or a grant or any time, private time for research. I started taking every Friday afternoon and evening and night until late to look and to look in depth to this registry that he was holding and to contact the families and track the children and see what symptoms they were expressing. So it came into my vision immediately that even if this was an adult disease, there were children that were starting to express the disease very, very young in life. And this is where I started going further into my research and publishing the paper and sharing with the world what I had found with Professor Brugada. And this is how my path with the children with Brugada syndrome started. And since then, well, we have been through a lot of different challenges, but we are now in the point where we are unifying as medical doctors in the pediatric field to try to give an answer to this family. So with this in mind, please let me come into the topic of interest, that is pediatric Brugada. I'm now based, as you shared, at University of Montreal. I have been there for the last 2 years, and we have been able to relocate our registry to Canada now. And this is an international initiative that I will share with you later, that is withholding the expertise of pediatric Brugada around the globe. So let's start by a simple question to the audience. Here we have a set of kids, 12 young children who all seem normal. They don't seem to be unhealthy or have any predisposing risk to have sudden cardiac death. But we know that there's one child that could have Brugada syndrome. The difficulty with this syndrome is that there's no way of identifying it either by the appearance of the child or even by markers like the echocardiogram or even the electrocardiogram when the child is not presenting in arrhythmia or with fever. So from all these children, we could say, well, maybe the ones that are older, like the adolescents, are the ones that may be presenting Brugada syndrome, because we know that it may present sometimes later in life towards adolescence, or maybe some of them that have more Asiatic features, because we know that there is a higher incidence in the South Asian Pacific area around Japan and the Asian Pacific territory. So we could say either this is an adolescent or this is an Asiatic person. And indeed, we will be surprised to identify that, in fact, the girl that had presented with sudden cardiac death as a patient of mine in the year 2018 was this little British girl who at that time was 18 months old. So, and this is, and I share with you information because the family, after her event, decided to come out to the world to share more information about pediatric Brugada syndrome, and they went to the Sunday Mirror, which is a very popular newspaper, weekend newspaper in UK, and they actually gave a testimony of how she had sudden cardiac arrest and survived the arrest, and with the aim to increase consciousness about this disease. So this is Emily, and my experience with her started with a phone call in the middle of the night, and I will now share with you the worst case scenario of pediatric Brugada syndrome, knowing that this is just the minority of patients, that the the largest proportion of patients will do very well and will not present symptoms. But I will jump from one of the extremes of clinical presentation to the other, so that we can encompass how the disease can present in the pediatric age. So I received a phone call in the middle of the night, and this was a 14-month-old girl that had sudden cardiac arrest at home, and she did have a history of breath holding spells. And these spells, for those of you that are not in the medical field, happen sometimes in some children that start to cry because they're upset or they're in pain, and all of a sudden hold their breath and can collapse and lose consciousness. And they're not dangerous in themselves, but they can be a marker of that there's something underlying disease to the conduction system of the heart. There was no family history of syncope or sudden cardiac arrest, and she has had diarrhea and vomiting for 2 days prior to the event. And this is important to note, because we're starting to see clues of the disease. As we will see later, there is a genetic factor that is triggered by an ongoing disease that can be a viral infection with or without fever. And she started this event in the family table as a breath holding spell, but then she collapsed and she could not really recover. So the family members that could not identify a pulse, they started chest compressions. And this is also very important, because since there is a high awareness in society and outside the medical community, but in all the fields of society, of the relevance of resuscitation maneuvers, and people are getting trained in resuscitation, we are having more children that survive this first event. So this girl was assisted by the emergency system. She was not responsive, so she was resuscitated, and she came then to the intensive care unit in Wales. And she has this ECG that I do not intend you as non-doctors or outside the medical field to interpret, but there's one of these parameters that is very important and is the marker of the disease, and it's an abnormal finding in the leads that look at the top of the heart. Okay? So this is the marker of Brugada syndrome. And when you receive as a doctor this call in the middle of the night, and they share with you an ECG that is already typical, so you have the diagnosis there, you feel in front of a tsunami wave. Why? Because just by looking at the ECG, you have identified the disease of the patient, but because it's such a rare disease, you know that it will be a challenge for you to convince your other medical colleagues, even within the pediatric cardiology field, that this is pediatric Brugada. And this is what happened. And this is what I call the solitude of the rare diseases. And we have Catherine Timothy also in the audience. I know that she feels sometimes the same when she knows what a new diagnosis of Timothy syndrome or Brugada syndrome or CPVT or many other diseases that are potentially very dangerous can mean to families and also to the medical community. So I, of course, was very, very involved with this girl. She did very well, and this is a good thing, because children recover very well from, if treated well, from cardiac arrest. She didn't have any long-term brain injury, even if she was having seizures in the beginning, and had all kinds of screenings, including brain CT, toxicology, to make sure that she had not intoxicated with any medication, because the grandmother who was taking antiarrhythmics was living with the family. And we identified by the virology screening a co-infection by 3 regular, very innocent viruses, but that may be put together in a susceptible territory of a SHID mutation brought up this terrible case. So she did well. She received an ICD. And again, this is another important point, because at this point in the medical field, we do not have any means of protecting these children. There's no drug, there's no magical drug that we can give them to protect them from cardiac arrhythmias. The only way that up to now a child that has already had sudden cardiac death can be completely protected is an ICD. So we have, and we struggle still, pediatric electrophysiologists, because we have to adapt our adult technology to very small children, and sometimes we struggle. But I share with you this initial picture of our patient to let you know and to share how, even if she has been in the worst scenarios, she survived, she got her ICD, and she's now living a normal life. And this is to say that we have to put all our effort in trying to identify these children, and also trying to share with our medical colleagues from pediatrics and pediatric cardiology to be aware that this disease exists, and to open their eyes to the fact that if non-identified, it could result in sudden cardiac death at a very young age. I did this slide to help a little bit understand the mechanism of the disease. So this is the DNA that contains all the genetic information of the cells to express everything that we are as human beings, the good things, the not so good and the bad. And I put this red dot here to show that there's a small modification in the DNA that makes that the sequence change. And the DNA is a succession. It's like a book, huh? And even if there's a misspelling in one of the sentences of the book, this can result in a severe abnormality in the proteins that are part of the cells of the heart. And there's a protein that is very important that is called sodium channel. This is like a little door in the membrane of the cardiac cells that are called myocytes that regulate the flow of an electrolyte that's called sodium, that is very, very important for the transmission of the electrical current in the heart. So I put here a little door in the membrane of the cells that works well, and there's sodium that enters and exits without difficulty. But when there's an anomaly in the information to construct this door can be very narrow and be almost closed. And I express this here. We see the channel that is abnormal, and this results in an impairment of flow of sodium from outside to inside the cell. And this predisposes the cell of the heart to be very unstable electrically. And this is what causes an abnormal electrical pattern that in the ECG we call Brugada pattern, in honor to the discoverer of the disease, Pedro Brugada. So we know that there's a susceptibility in the heart because of this genetic abnormality. And we also know that when the disease expresses very early in the young age, there may be other concomitant factors that take that susceptibility above the threshold of expression. In this girl, it may have been the fact of having 3 viral infections at the same time, but there can also be drugs that affect the opening and closing of this little channel or door in the myocardial cells. And we know that fever by itself disrupts and distortions the opening of the channel. So there are a lot of environmental factors that we know, and many others that we still do not know. This predisposes patients to develop this abnormality in the ECG that is called a type 1 ECG. And we know that when a child presents with this pattern in the ECG, the potential arrhythmias are imminent. The possibility of having an arrhythmia with this pattern and an abnormal electrical rhythm that doesn't allow the heart to contract, unify, but makes a chaotic electrical activity in the heart become very, very high risk. So our patient did well, and she did well because we could identify the disease early. We could provide appropriate care. We could start a medication that's called quinidine that decreases the susceptibility for arrhythmia, even if it's not completely protected. And we could provide her of an ICD. And she's now alive and doing well and living her life despite her device and going to school and behaving as a normal kid of her age. She's now 5 years old. And as I said, this for me, when I started to prepare this meeting today and this talk, I came to note that this report on the Sunday Mirror dates from April 2019. And I thought it was a good way to commemorate within the many patients we have with Brugada syndrome that survive and are doing well. This was a good way to commemorate 5 years after meeting her for the first time, to commemorate her survival and all that the family has done to expose the disease. So the difficulty with our disease of interest, with pediatric Brugada syndrome, is that patients can present with very, very different scenarios. We have, as doctors, as pediatric cardiologists, we had most of the patients reach us because they're young family members in families that had a diagnosis of Brugada syndrome. And they came to us referred by their pediatric doctor or their general doctor or even the cardiologist of the adult member in the family to follow them and to screen them. And we don't have many tools to give them data-based information that can share their prognosis. We know that almost all these kids have a very benign prognosis, but we still do not know their individual risk. We do not have guidance or protocols in our community of cardiologists to share that are based on evidence and to say we should follow patients every year, every 2 years. We don't have protocols yet because we are starting to understand and know this disease. And we don't know what tests are better to identify. We don't know if provocative tests are the best way to treat children. So there's a different management and practice all over the world. And this is also important because with our group and Christine Stratman, one of our collaborators, we have recently published an article in Europace about this and showing the discrepancy of practice we have around the world in the pediatric community regarding Brugada syndrome. And of course, from these children, we need to identify who are at risk of malignant arrhythmias, just to make sure that we protect them and follow them more closely, and also to be confident in sharing with the families that most of the children, the vast majority of children, will do very well. And the second scenario is a scenario that is dramatic, as the one that I shared with you of our very young patient that was not even 1.5 years old. And they present with severe breath-hold dispense or severe syncope or even seizures that are actually masking arrhythmia events with hypoperfusion of the brain. And they can go to the extent as our patient presented with sudden cardiac death. So we know nowadays that quinidine decreases, stabilizes the channel and decreases the possibility of having arrhythmias, but we do not have yet a safe drug to preclude the implantation of defibrillator, which is a shame because young children with an ICD do not do well and not have and have sometimes complications. But up to now, this is what we can offer to them. So our aim and our work needs to be on identifying these children that have higher risk, on working with pharmaceuticals to develop drugs that can prevent arrhythmia, and eventually develop also some gene therapy that could modulate the expression of the gene and the disease. So with these goals in mind, we have been working together for the last 4 years to develop a community of physicians that are interested of giving answers to families. I started my PhD with Professor Brugada in 2017. I actually started 2014, but I presented my PhD in Pediatric Brugada syndrome in the Free University of Brussels in 2017. And from then on, my PhD was not the end of my relationship with the disease, but it was the beginning. Since then, we have been advocating and sharing information with doctors in congresses all over the world and assisting families and receiving second opinions about patients admitted in different countries with a suspicion of Brugada syndrome. And we thought, and we realized that the only way to increase the awareness, understanding, and to be able to propose families means of stratification, follow-up, and eventually in the future of therapy was to share information and to construct a network of physicians with intertwined with collaboration from family members and patients to work together with a common goal. I think that in this new era where we are moving away from the paternalistic approach to medicine, where the doctor is the one that knows everything, and we are moving into a more networking, collaborative way of dealing with health, and it is of main relevance to have families and patients within our advocacy groups and within our protocols for care and within our guidelines for management. So this is the way we're trying to move forward with our project. We have now a consortium with many countries involved around the globe. We have already collected produced many articles, and we have recently produced one about what is the practice around the world. We have been collaborating with SADS UK, and we have again to thank SADS UK for their support for 2 years with the possibility of having Christine Stratman as research assistant, and from this collaboration with SADS UK, we have the roots of what is now the registry. So our gratitude to them. And now on the other side of the world, our collaboration with SADS Canada and with SADS US. I think that we are there for each other, and we are working together towards a common goal. So we had here Einstein saying, God does not play dice with the universe, and that is real. And then we have Stephen Hawking that says, not only does God plays dice, but he sometimes throws them where they cannot be seen. And I decided to put this slide to share that the genes are starting to open their secrets to us, but we are still far from understanding everything what is happening. So we are working towards that goal, but there's still a lot to be known. And before finishing, I wanted to share with you some of the information we have already collected from the registry. This is an analysis we did a couple of months ago when we had 173 patients collected. This was from the, I wanted to do an analysis by the end of year 2023. Now we have more than 200 patients in the registry, and they're very young. Look at here, the mean age of diagnosis is 8 years. Okay, sorry, onset of the disease, it's 8.7 years, but it took them more than a year to be diagnosed. And I think that this is the reason underlying this is that doctors do not know, many of them do not know the disease. So this is a little bit what we have found in terms of gene and expression. There are many, many different mutations. The gene is very complex. The protein is very complex, but we would like to move forward to the next step and be able to perform centralized deep genetic testing in these children that presented with the disease so early in life, so that we can see what concomitant factors are making this disease that can be silent, expressed in such a catastrophic way. So some messages for us to share. Pediatric Brugada syndrome is a clear entity. In the past, when I was speaking about this, maybe 6-7 years ago, people, even doctors, were looking at me and they didn't believe me. And these same doctors are now telephoning, speaking to me on the phone, saying, you know, I listened to your talk a couple of years ago, but I didn't really pay attention because I thought I would never encounter a pediatric Brugada syndrome, but now I have one. So our task is to increase the visibility of the disease so that doctors can have the idea in their minds and identify the rare condition when they face it. The children have shared characteristics with adults, but also express their own features. And this is mostly seizures and breath holding spells. Once it appears, it can be very rapidly progressive. And this is why we need to increase the awareness to be prepared to act and face and protect our children. The difficulty we have is that even if you go to the doctor and the child has Brugada syndrome, the abnormal ECG is not present all the time. It can fluctuate. It can be present during fever. It can be present during a viral disease, but it's not always there. And of course, we need to work more in genetic testing, because we know that the majority of children do have an abnormal variant that can be identified in their genes, but we have to understand a little bit more of why is this variant expressed so early. Okay, if there are other genes that modify the variant, if there are viruses, or if there's any other environmental effect that triggers the expression of the disease. So our registry now has many centers. We are having a global meeting next week, and we have already, I think that more than 20 people that responded positive to the meeting. We are collecting data. We have collected data from many centers, but there are still many to be enrolled. We have more than 200 patients already enrolled. We aim more than 500. I always put this bar higher. We have our weekly meetings with our research team, and the last time I spoke to them, I said, well, I would like to have 400, and now I go for 500. And I think that this is not about numbers, but it's about people getting together in a collaboration that can achieve results to share with families. We have already published our first paper from this network, and we are going for a second comprehensive paper for the end of the year. And we have also recently launched a website because we have patients calling us from different parts of the world, from UK, some from Central America, saying that their doctor, their center do not want to enroll and they want to do it on themselves. So we would like to offer these individual patients the possibility of self-enroll. So we have launched the website so that we can allow people to be part, even if their medical community is not involved in the registry. So I will share with you perhaps in a couple of minutes. This is our new website, and we have a specific section for patients and families. And here you will find all the information about what is the Brugada syndrome, how it may affect you and your children, how can we live with Brugada, and also, very importantly, what is the registry, what is the aim, and how to contact us if you want to be part of this initiative. So with this, I will end here so that we have a possibility of interaction and of having questions from people, and that we can hear what families and the audience has to say. Thank you very much.